before we go into the classifications of all this nonsense, let's talk about a little bit of the pathophys of seizures before we go into all the classifications here. So, first of all, seizures, the pathophys definition is an uncontrolled electrical discharge from the neurons in the brain. It's almost like you're having a heart attack in your brain. Your brain is firing so many different types of brain waves, and it's not succinct. Actually, a heart attack probably wouldn't be the best description. More of like a dysrhythmia of the brain waves. So we're going to be talking about an EEG versus of the brain is pretty much like the EKG and the ECG that we do in the heart. So, first of all, your seizures are idiopathic. We don't really know why seizures occur. We have links in terms of what causes seizures, but we really don't know the pathophysiology of why seizures are caused for certain patients versus non-certain patients. And mostly it's actually the major cause for chronic seizures like epilepsy, which is just chronic seizures that are, it's not normal, but chronic seizures for patients, usually associated with some type of genetical disorder. But in terms of your actual why people get seizures in terms of links, there's a few different links, and it's really always associated with any type of brain swelling or brain involvement or even brain infection. So we already went over genetics. Any type of infection that gets into the brain that increases intracranial pressure, your patient's going to have possibly a seizure. Any type of trauma or even a brain tumor that causes pressure in the brain will cause a seizure. Any type of decreased oxygen, ischemia, fancy words for low oxygen, will cause a seizure. Any type of ETOH, or alcohol, or drug withdrawal will cause a seizure. Let me see here. What else am I missing out? Okay, so other than that, we're also going to talk about later the different types of triggers that can trigger a seizure for different patients. But let's go into the classifications of all the different types of seizures right here. So we have general types of seizures, we have partial types of seizures, and then we have unclassified types of seizures that account for 50% of all types of seizures, okay? Let's talk about the ones that we can classify in general and partial. Actually, before we even go into this here, I want to say that there's a condition called status epilepticus. It's almost like with your lungs, status asthmaticus, basically meaning that your patient has had a long duration of a seizure, like more than 30 minutes, or more than 2 seizures within a 15-minute time span. So a seizure, then less than 15 minutes, and another seizure. That is a medical emergency, and that will possibly be on your test. So don't forget status epilepticus. This is just describing the type of seizure that people are going into. Okay? All right. So for your general type of seizures, you have a tonic-clonic seizure. Now we can break these down into your mind and thinking. Tense for tonic, very tense, and clonic for clicking. So if it's a tense and clicking type of seizure, or jerking type of seizure, which is the most common type that we see in like movies or Grey's Anatomy, and we see like tense and tonic-clonic, jerking or clicking, and very tense. That's your tonic-clonic, what used to be called your grand mal seizure. Basically the gold standard of seizure, we can say. Your tonic seizure is just tense. Your patient's very tense. No jerking, just tense. That's your tonic seizure. So think in your mind, Next is your clonic seizure. Think in your mind, clonic meaning clicking. Clicking. Okay? Just clicking, jerking motion. Okay? That is your clonic type of seizures. For your absent type of seizures, we have, this is actually most common in children. It consists of loss of consciousness, almost like, I like to think of it like Ferris Bueller's Day Off, when everyone's in the classroom and the teacher's up front saying, Bueller, Bueller, right? You have an absence of any type of activity. Your patient is there, usually with a lot of pediatric children, just an absent type of seizure. Your patient is conscious, but is not interacting, okay? Let's see here. For your myoclonic seizure, myoclonic, general features here, we're talking medium clicking. So think again, in your mind, clonic meaning clicking, myoclonic, medium clicking, medium jerking, okay? For atonic, tonic, remember tonic meaning tense, tense. So atonic, without tone or without tension. A meaning without, tonic meaning with tone or tension. So without tone or without tension, very flaccid, very loose, okay? For your partial type of seizures, you have two different categories here. You have a complex as well as a simple type of partial seizures. So let's see how I'm doing on time here. So for your complex, you have automaticities. So this can be involved with your patient doing a repetitious activity. Most of all, we see it like lip smacking or biting, and like not tonic, but just, or your patient will be picking at something. And that can be classified as a type of seizure. I know it sounds weird, but it is, okay? Then with our partials, we also have simple, which your patient is 100% conscious. I draw a little house here because the lights are on, but nobody's home, okay? Your patient is fully conscious, and you have your patient that is, lights are on, they're looking, but no one's home, there's no activity, if you offer your patient stimuli, they're not going to respond to it, okay? So with your general type of seizures versus your partial, this is probably what you're going to be most tested on. Think tonic, tense, clonic, clicking, jerking motions, okay? And again, before we go on into nursing interventions for our seizures, please remember that your status epilepticus. Epilepsy, meaning that we have epilepsy, are getting way too ahead of myself. Epilepsy meaning that you have a continuing of normal type of seizure activity. And I hate to say normal because seizures really should never be considered normal, but you have a reoccurring seizure history. That's with epilepsy, okay? Seizures themselves are the activity of actually having a seizure. So when your patient goes into status epilepticus, that's almost like the worst type of thing that your patient can have. Because we're going into a seizure that cannot be reversed without medication or nursing interventions or medication interventions. And so we're going to talk about exactly what we do in this medical emergency called status epilepticus, or if your patient is considered having any type of seizure, we're going to go into nursing interventions, okay? Let's go into our nursing interventions when your patient is having a full-on seizure. Doesn't matter which kind of seizure they have, but again and again, status epilepticus is when your patient has more than a seizure for more than 30 minutes, or status epilepticus is when your patient has 2 consecutive seizures within a 15-minute time span, okay? So they have a seizure, then if less than 15 minutes medical emergency. Your patient can go into brain death or a coma, and it's very, very bad. So let's talk about what to do if your patient is having a seizure. So, during a seizure, our main priorities here, obviously we want to stop the seizure. We want to give your patient medication, either an IM injection or an intravenous solution of benzodiazepines. And benzos are your PAM and LAM drugs. And I have a great video talking about a Mercedes-Benz with PAM and LAM, living the fast life and how they fast absorb in your body. But that's our main goal in terms of medication administration. We want to stop the seizure. But if your patient just falls over or is in the hospital and just starts having a seizure, our two main nursing priorities are safety and airway breathing circulation. Now, you've probably seen it on Grey's Anatomy, or you probably have patients, family members, trying to put a bite guard in your patient's mouth. I've had patients, family members, kind of like stick their finger into a family member's mouth when they're having a seizure, thinking that, they're going to bite their tongue off. You can actually bite someone's finger off if you're having a seizure, if they bite hard enough. So, don't restrain your patient. That's what we used to do back like in the 80s. We used to put bite guards in too. But right now, what we're doing is safety. Let your patient seize, but make sure that we clear out anything in their path and make sure to monitor your patient. Do not leave your patient. Keep them safe from hurting themselves if they're having a tonic, clonic, or tense, clicking type of seizure, knocking things over onto themselves, okay? Airway breathing circulation, get your suction equipment ready because you don't want your patient to aspirate on themselves. If they're having a foaming type seizure, we're going to suction their mouth. If we don't have any suction, we're going to try to position your patient on the side to help with drainage, okay? Don't try to restrain your patient. Don't try to hold them down and say, stop seizing, That's what we don't do anymore, okay? So during seizures, we're going to stay with our patients. Stay with them. Call for help, yes, but stay with your patient. That's a big one on your nursing priorities, prioritization, and could even show up on your test one day. So ABCs and safety, those are the two big ones. For your post-seizure, I'm going to show you the assessment here, but just to warn you, your patients will be in a post-stictal phase. And post-stictal meaning basically post-seizure phase. Your patient's going to come out swinging probably and very, very agitated. I've had patients very angry, not knowing where they're at, very confused. And for some reason, a lot of seizure patients, when they stop having a seizure, they want to get up and move and try to get out of bed. And they're going to hurt themselves, probably cause themselves to have a hematoma on their head, they hit the ground or break an arm or something. So make sure safety is the first thing, okay? First things first. That's why we're going to assess our level of consciousness when your patient is post-stictal, post-seizure. Level of consciousness. Do they know where they're at? Do they know their name? Do they know the date? Things like that. Are they AO times 0? Are they just combative and confused? Most of the time they are, okay? We're going to do vital signs. We're going to make sure your patient has stable vital signs, okay? Now, obviously, post-stictally, you're going to try to slap a blood pressure cuff on, they're going to rip it off and throw it back at you. Doesn't mean that they're a bad person. It just means that they're very confused, okay? Neuro assessments. We want to test their grips. We want to look in their eyes. We want to know their level of consciousness. Are they all the way there? Are they orientated? Do they know where they're at? Do they know their name? But again, neurologically, post-dictally, they're going to be combative. So just watch it. Just take your time with your patients, okay? For your documentation, this is really big, actually. This is really huge. Documentation with your patients. For documenting, we want to document the onset of the seizure. If you were there, or if the family member's there, we want to know when the seizure happened, like longer with our chronically seizing patients, our epileptic patients. We want to know what type of seizure is it. Did you see the seizure? What type is it? Remember the classifications we just did. Was it a tonic-clonic, a tense clicking? Was it an absence? We're just absent. Was it a myoclonic, a medium click? What kind of seizure was it? And the last thing that helps us to identify what caused the seizure or was linked to the mechanism of action in terms of what preceded the seizure was any type of trigger or any type of aura. And an aura basically meaning, did your patient feel anything before the seizure? So we're going to ask this to our patients directly. So this information is going to be gathered after our patient returns to their level of consciousness state, okay? But again, your patient will be very combative after their post-ictal phase. Keep them safe, ABCs, and don't shut the video off just yet. We need to go over our meds again, our PAM and LAM type of drugs. These are our emergency drugs to stop the seizure. It's our Ativan type of drugs, okay? So Ativan is the brand name. PAM and LAM are the generic suffixes to the name, to the drug. And these are our benzos. Benzos stop seizures immediately, depending on the dose, but we want to administer PAM and LAM medications as soon as we can. And that is actually one of your first nursing interventions in terms of medication. So if your patient has an IV, sure, keep them safe, keep their ABCs good, but administer PAM and LAM drugs, benzos, immediately. And I see nurses sometimes on neurological floors, the neuro ICU. Patient has a intracranial pressure, and they're constantly seizing. So your nurses will have Ativan inside their pockets, ready to be pulled out and dispensed to their patient whenever they have seizure activity. So I've known some nurses to take home accidentally their benzos, which is not a good thing, which probably is a good thing for the nurse, but I'm just kidding. But yeah, nurses will actually carry it on them for their patients in the neuro ICU who have chronic seizures from anything that causes increased pressure in the brain. But administer PAM and LAM. Don't forget that, PAM and LAM. That's like your albuterol. What albuterol is to your asthma patients. Clears it up right there. That's the fastest acting in terms of bronchodilating the lungs for asthma. PAM and LAM benzos are the fastest acting in clearing up seizures for your seizure patients. So make the link, okay, guys? Think about it. Don't only think about, seizures. Try to relate things. Let's say your patient's having an MI. What are we going to give them? We're going to give them nitro to dilate the cardiac, the coronary artery, right? Seizure patients, we're going to give benzos so we can decrease that neurostimuli immediately. It happens fast, like a fast light. And I go into more on benzos and breaking them down a little bit better in the video on benzos. So that's it right there. Let's go into next. We're going into next. So how much did you study for this next test? I know on a lot of nursing tests, they like to confuse you guys with these three criteria here. You have an EEG, you have an ECG, and you got an EKG with the 1, 2, 3, and the ABC, and the elemental P. Okay? Yeah. It's getting kind of lonely in this room with a whiteboard and a camera, okay? So I gotta entertain myself somehow. Okay, let's get into it. EEG, ECG, and EKG. Now, egg versus your ECG and EKG. Egg, think egg in electroencephalogram. I'm not even sure if I'm saying that correctly. encephalogram. That's right, I am. Think egg in terms of your egg head. Egg head, okay? Egg head, we're talking about your egg head, okay? There's an egg, and that's an egg head, okay? Egg meaning we're looking at the electrical conductivity of your brain. What's going on in your brain, okay? For your ECG and EKG, we're looking at your heart. EKG, we're talking about 12 different views of the heart. ECG, we're looking at 3 different views of the heart. Those seizures, do we really even care about the heart right now? Heck no, we don't. They just like to confuse you in your nursing school stuff, okay? We're talking about egg head. Egg head. So we're looking at your patient's electrical activity in the brain, in the EEG. So we hook up all these electrodes to the brain, and we have your patient go and look at these flashing lights, because that's usually actually what causes seizures. That's the most common type of trigger with patients with seizures. And we're trying to see at which focal points of seizures caused in the brain. Because there's some types of surgical interventions that we can do to combat seizures itself. So we do this as a diagnostic test. Before your patient goes, we have them take no caffeine, no coffee, okay? That's why I put a little coffee cup and I cross it out. Yeah, so no coffee. No sleeping during the test. We need your patient fully aware, looking at the lights, following the lights with their eyes, and focusing, okay? NPO? Do we need your patient NPO? I don't know. No. There's really no indication of having your patient NPO. So that comes up in terms of your test. I couldn't find any information in my textbooks in terms of having your patient NPO, but I will say that you need to make sure your patient's hair is washed, you need to make sure that no lotions are being used and all that stuff, because we're actually hooking up like little electrodes all over the head and trying to see the electrical conductivity of the brain. So if we don't have a good connection and the electrodes are slipping off, we need to make sure that the electrodes stick. We don't have any hair gels or lotions or Victoria's Secret, Bed Bath & Beyond, or Bath & Body Works, all that sort of stuff, you know what I mean? So again and again and again, egghead, think egghead, we're looking at the brain, okay? Don't get it confused with your ECG or your EKG or the 1, 2, 3 and the LMNOP, all right? Cool. All right, so next video, guys, let's go over our trauma in the brain.